So we have our law enforcement criminal justice implementation team, and actually we have 2 guest speakers in addition to our 2 co-chairs. So we have 4 speakers who are all going to be really brief, right? So I want to introduce everybody. So Virginia Chavez is sitting right next to me, and she is the Assistant Chief of Operations at the Bernalillo County Metropolitan Detention Center, and she is a 16-year veteran MDC. And I'll say that she is one of those quiet people who gets a lot of work done. I'm really, really pleased to have her as a co-chair. If I had a criminal justice basketball team, she'd be on it. Okay, and Lisa Simpson over here. First of all, this is like the other part of the dream team. They've been working, I don't know if you've heard that MDC has had severe overcrowding, the Metropolitan Detention Center, and they've got it down to under 1,800 people now, and they're saving the county $1 million a month. That's something to be saying. These are 2 of the hardest working people I know because I can't get them to come to meetings. Okay. All right, so Lisa, let me tell Lisa's story. Well, Lisa comes. She's an attorney in Albuquerque focused on civil rights and specifically represented incarcerated individuals with health needs. She moved from legal representation to service provision. She founded Crossroads for Women, which was for women with co-occurring disorders cycling through incarceration, and then the Vera Institute of Justice, criminal justice reform work in New Orleans. She returned to Albuquerque to work on the jail population reduction strategies, including developing alternatives to incarceration, which that video was just about, which is what a lot of our strategies are about. And Kelly Bradford, right here, has worked within the criminal justice system for over 15 years. She worked at the DA's office as a coordinator in the Victim Impact Program, worked with juvenile, misdemeanor, and felony cases, currently works for Bernalillo County in the public safety as the Adult Detention Reform Coordinator, works closely with Lisa Simpson as a team to work strategies and initiatives to reduce jail population and create alternatives to incarceration. And my other co-chair of this team is Dr. Tim Condon, who I told you all about this morning, who gave us that fantastic talk. So why don't I let Virginia go ahead and get started.
Thank you. Thank you for enduring the long day and for staying here for the last hour. The resources that are being drained by all these issues that we're facing is tremendous. The resources hit law enforcement, APD, BCSO, fire department, the courts, and the Metropolitan Detention Center. And I don't think that it should, but that's what we're faced with. Oops. What does MDC look like? I wanted to give you a snapshot of what MDC is looking like. Our population, I don't know if you can see that. Our population, this is as of yesterday, was 1,883 inmates, and that includes the CCP inmates as well. We have, I can't see that, community custody program. I can't see it. We have 1,589 males, which is 84% of the population. Females is 294 females, which is 16%. The largest population in the jail are Hispanics, which is 52% of the population. The majority of our inmates the age range is 30 to 39, and that's 34% of our population. Of the 1,183 inmates, 35% of the population, or about 647 of the inmates, are on psychotropic medication. For 2014, we detoxed from alcohol 248 inmates per month, and an average of 346 inmates per month were detoxed off of opiates. for a total of 593 inmates that were being detoxed at the Metropolitan Detention Center. On average, we have 90 inmates on methadone maintenance at any given day at the Metropolitan Detention Center. So what does that say about MDC? We've become the largest therapeutic community in Bernalillo County and probably the state of New Mexico. So what has MDC done since the last summit? We've issued a new RFP for our medical, mental health, dental, and we've included methadone maintenance. And the reason for including methadone maintenance was for continuity of care for our inmates. We required the medical provider to enhance their discharge planning. We've issued an RFP for family services, support services at MDC. And what we're going to be doing there is we're going to be providing a waiting room for families and children of the people that come in to visit the inmates while they're incarcerated. And we're going to be providing interactive activities for the children. We're also going to be interviewing the family members, asking them what services they need. Also, having them enroll in Medicaid while they're waiting for their visit at MDC. We're developing teams with our medical provider, with our behavioral health experts. We're going to have social services coordinators, along with the Department of Health. We're going to sign the inmates up for Medicaid while they're incarcerated, and then upon release, we'll submit the application. We're going to enhance their discharge planning in coordination and collaboration with all of the people that I mentioned above. We also budget, and Lisa and Kelly will speak to some of the initiatives that we have, additional initiatives that we have. We have an MOU with UNMH for a fast-track program, and that's to assist with discharge planning for our seriously mentally ill inmates. And we're going to enhance that. We're in discussions now we've collected data for the last year, and we're going to see where the needs are, and we're going to continue that effort. In the last year, they've serviced, I think it's a total of 59 inmates upon discharge. We also have an MOU with UNM regarding the research study that Dr. Condit mentioned. And we have we're working on an MOU with the Department of Health, and they're going to assist us with Narcan education and also with our discharge planning. And now I'm going to hand this over to Lisa so that she can speak to the other initiatives that Bernalillo County is working with. We also want to make sure that everyone understands that we're not in this alone. We need everyone's help in order to decrease our population, to assist all these people that are in great need and don't belong in the jail. And in order to do that, we need all your help.
Okay, thank you. And I want to thank Dr. Condon. He was scheduled to go before us. We were asked sort of last minute to jump in and give a little bit of an update, and I had a 5 o'clock appointment I had to get to, so we appreciate being able to jump in. And coincidentally, I carry my PowerPoint with me everywhere. It's a strange form of a security blanket, but I happen to have it with me, so we were able to jump right in. So, as has been mentioned, Kelly and I work within the Public Safety Division. Our task was to reduce the jail population, both through criminal justice strategies, but also through developing alternatives to incarceration. So it's that latter area that intersects with behavioral health most closely. But the former area does as well, and so we were asked to give a little bit of information on that as well. I was reminded of something Anita said earlier in response to one of the comments, and that is, let's not look at just providing services in jail. That's really not where services should be provided. And I think the point of the comment was a good one, that it is an important place to intervene with people, to take that as an opportunity of intervention. But the research is actually very clear that reducing incarceration or reducing time in incarceration is actually associated with better outcomes in itself. So we really don't want to build a system where people get services by going to jail. We want to avoid them going to jail. So the first step in our work was to try to reduce the population, and this chart is a little bit dated. It's the last time we did this PowerPoint, but Kelly is going to give some updated information on where our population is at.
So this diagram really shows through the end of November, and if you look, you can see where there's some population declines that started occurring in March. And so, and Lisa and I will go into more detail, and that's where a lot of the criminal justice initiatives that were developed by all the criminal justice stakeholders really went into play. So now we sit here in December, and so where are we at? So what we can say is the population has decreased by about 23% in December compared to December 2013. That 23% is about a little over 500 people. And while doing that, public safety, of course, has been the main focus. We don't want to just be putting everybody out in the street, but it really showed that there's a lot of people in the jail that didn't necessarily need to be in the jail. And so that's where we're trying to focus. As of December, our average in-house population that does not include CCP, which is a community custody program, or out-of-county shipping, was 1,784. We have a larger capacity that we try to standard, but we have an agreement to stay under the capacity of 1950. And that allows us to place people in the jail in different classifications in a safe way, and also by how pods are governed on who can be there. With that said, our community custody program is 218, and in December 2014, it is the first time we've been able to say that we aren't shipping anybody out of county. In October of 2013, we actually peaked, and we had over 700 people shipped out of county, and it cost the county about $7.8 million. So our goal is to get our population under control in a safe environment for both offenders or sentenced folk and our staff, and not have to spend this crazy amount of money in order to do that. So our population is down. Initiatives have been implemented. We're working with the criminal justice system to implement more initiatives, which should help further give us a healthier population in the jail.
Great, thanks. Did you take my notes? I think I did. And just to give you some framework on where our population should be, for a county of our size, at the national average rate of incarceration, we would be incarcerating about 1,550 people. So we've been way over the national average. We're still not there yet. That is, in fact, our goal, even though the 1950 is one that's imposed by the federal court in the jail conditions litigation, but we hope to reduce it far beyond, below the 1950. So, and I wanted to mention one other thing that Kelly and I have not really been involved in. It's also within the Public Safety Division, but it's the Department of Substance Abuse Programs. That obviously is a department that has been serving as an alternative to incarceration in a number of just different ways. The MATS program, the Public Inebriate program, and actually it's through DSAP that the new program that was spoken about earlier for adolescents in transition, with heroin addiction, is going out of that program. And Katrina Holtram is here. She's the director of that department. Any questions related to those programs would really need to be directed to Katrina. But we focused a little more on the mental health side. And I wanted to say, yeah, can you advance to where you? You probably don't want to watch this. It'll make you dizzy because we're going to go through the court initiatives real quickly to get to the behavioral health ones. But Virginia spoke about some of the statistics. We recently, the Institute of Social Research recently took another look at who's on our psych services unit caseload. That's the PSU, you'll hear it called. And specifically looking to see how many individuals in the jail have mental health problems, how many are severely mentally ill. And for better or worse, we kind of come up pretty close to the national average. About half of the people in our jail have some form of, well, I should say they're on the PSU unit, and so, or caseload. And so that designates them as having some form of mental health issue. It may be severe, it may be not severe, it may be something temporary associated with being incarcerated, it may not. And that's about consistent with the national data, which is about 60% of men and 75% of women identify as having some level of mental health issue of people in jail. With severe mental illness in our jail, using criteria that were consistent with a study done by Hank Stedman out of the Gaines Center, about 27% of our women have severe mental illness, 17% of our men have severe mental illness. And of course, many, probably most of those have a co-occurring substance addiction, and this doesn't include people who are in jail with only a substance addiction, that is not having the co-occurring mental illness. So there's national statistics on that are typically around 75–80%. So we're consistent, for better or worse, with those statistics. And now I want to echo something that Mike Robertson had said earlier, and that is that the criminal justice partners that we work with are very cognizant of this population and this problem. And I know there was some surprise that they really want alternatives, but that's actually been the case for some time. There's a huge appetite among the criminal justice partners for providing alternatives, for getting people out of jail. There's been a sense that they don't have the tools to do that, that the programs just don't exist. And I would say for this population that that's true, that I know there's often talk about, well, everybody just works in silos, and we just don't know of the other programs, or these linkages don't exist. And there's certainly some truth to that, but the problem is that the services that these people need often aren't there. And just to give you an example, as was mentioned, I did operate Crossroads for Women for some years, and during that time, our waiting list to get into Crossroads, which provided housing and support services, was about 2 years. And more recently, we had, I'm not running it anymore, but I'm still very much in touch with them. They had a woman that was accepted into Maya's Place, which is a congregate site specifically for women coming directly out of jail. There was a woman that recently was able to get into Maya's Place who stayed in jail for 7 months waiting for a bed. And that's not uncommon. A court order will say, I will release this person if they have a program to go to. And they will wait months and months and months waiting for that program. So it's not just that they don't know about programs, there really is a lack of services. And again, something Anita said is that it's not just any services, it's the right services for the right person at the right time. And you know, with our 2-year waiting list, if the person on that list happened to be somewhere we could find her, somewhere we could connect with her and was in a place, it was pure luck. I mean, 2 years later, who knows? So I see I'm going to have to run through these quickly. We need to get to the behavioral health one. Okay, I know, it's a little dizzying. Okay, so these are a list of the behavioral health initiatives we're working on. Supportive housing, the county appropriated $1.1 million last summer to support a supportive housing program for people involved in the criminal justice system, potentially people in jail, but also what we call the frequent flyers, people that come in over and over again. Medicaid enrollment, you've heard mentioned. It's been a challenge. It's hard to imagine, but there's a problem with the IT system in the state involving Medicaid enrollment, which makes it impossible for us to enroll people while they're in jail. And so it's been a logistical challenge to figure out how to do that. We're prioritizing that. We're working with Healthcare for the Homeless and UNM to do enrollments of people who are on our community custody program, and do enrollments of people who are on pretrial services. And we have one person in the jail who's doing enrollments as she only can right at the moment of discharge. So as you might imagine, that's a logistical challenge that we're trying to work through. Crisis Response Center, and actually, would you go forward? Keep going. Keep going. So I like to think of the Crisis Response Center not as just the Crisis Stabilization Center, but as a whole spectrum of services, and I think it's really important that we do that. It needs to be a crisis line, it needs to be community engagement teams, it needs to be mobile crisis response teams, crisis response centers, respite beds, and availability of long-term services. And the latter, again, ties into the supportive housing, because once again, if we take people in crisis to a crisis response center and we have nowhere to take them from there, we just turn them back to the streets, it's not only hard on them, it's a waste of resources. So we need to have those back-end services in order to make a crisis response center useful. And so there's obviously details about all of this. I'm kind of rushing through because we don't have a lot of time. But just in terms of what the county is doing in these areas, on the supportive housing, they've appropriated the money. We're working closely with the city. The city has also appropriated money, and we're trying to make that one cohesive program and to have a really true county-city collaboration on that. We're hoping that'll be up and running within months, but as we'd hoped it be up and running by now, so that's the challenge. Response system, and particularly the center, has been made one of the county's legislative priorities, and so it is on our legislative agenda. We have also proposed as a legislative agenda item that we really look at the Medicaid enrollment, and sort of the whole Medicaid system. And I have to say, since I was working on Crossroads in the 10 years of that, there were a lot of restructuring of the behavioral health system, and almost explicitly, the purpose of the restructuring was cost containment. And I think that hopefully we're moving away from that, because as we know, we pay for it one way or another, and it would be really good if we paid for it with federal dollars, which we have a great opportunity to do now with the Affordable Care Act. But the way our state Medicaid system is structured, we're really not poised to take full advantage of those Medicaid dollars. We have restricted things by definition and by provider eligibility, and so we're really not getting as much as we can from the Medicaid system. And so that's part of the county's legislative agenda as well, to really look at that and how can we make better use of Medicaid dollars. The other areas that we're looking at, there's some sort of overlap with the criminal justice initiatives. I don't know if any of you have ever dealt in the area of competency. We have people that are in our jail waiting forever for competency evaluations and then for a bed at the Las Vegas hospital. And so that's another huge area of need that results in people languishing in our jail. So as you can see, the long-term goals, some of those are criminal justice related, but to get the jail population down, to do better pretrial release, which also enables us to connect people with services faster and more efficiently, reduce recidivism by providing appropriate diversion and reentry. And obviously a number of these services are tied to not just getting people out of jail, but getting them out smoothly with prescriptions that can be filled, which has been a huge issue, with a warm handoff to service providers. And so that's a big part of what we're trying to build into the supportive housing program, but also to discharge from the jail generally. So that would apply to people moving into other programs. So thank you, and if you have any questions, we're here.
Thank you, Lisa. That was terrific. I wish I was able to see all of your criminal justice initiative and court initiative slides, because that's one of the things that you're going to be essential on our team as we work through those in the next couple of months and next year. Our group, the Criminal Justice and Law Enforcement Group, was the last implementation team to get formed, and it only got formed in the fall. And so I had the honor of co-chairing it with Virginia Chavez, and as you heard, there's lots going on at MDC. And this has been very rewarding. Of course, I've been working with her on this pre-release Vivitrol project, and they've been very supportive and helpful for that. One thing I told Virginia I was going to mention is a policy at MDC, I believe, is that when people are discharged, they get a 3-day prescription for whatever medication they may be on. That's just not viable. They should be getting at least a 30-day prescription for whatever it is, because in 3 days after getting out of jail, that they're going to run to the CVS or the Walgreens and get that thing filled is just not right. So it's an easy change. I don't know where the rule came from, but I don't see, since in fact it's not costing MDC anything, it just must be a rule with the medical provider. Would you like to comment, or I don't want to embarrass you?
It's actually written into the amendment, or the RFP that we wrote, and in order to fix that, we would have to amend the agreement, and that can be done.
Okay. See, this is the kind of cooperation and help that I've been having now for a year working with Virginia. I'm going to talk a little bit about what we haven't talked about today, and I don't have a lot of information. Nationally, drug courts are a phenomenon. I mean, something that a judge in Florida made up, literally made up, like 25 years ago. No evidence base to it. There was nothing. He just thought it was a good idea to have a specialized problem-solving court for people who had drug problems. What did he do? Very different than what drug courts are today. But nevertheless, it was an experiment. And so as that program started to grow across the country, the National Institute on Drug Abuse started to do some research on drug court, on the outcomes. And in fact, happy to say that, well, if you follow appropriate models for drug courts that's actually put out by the National Association of Drug Court Professionals, you have better outcomes. You have as good of outcomes versus non-coercion treatment. And so this is a phenomenon. And we don't have enough drug courts here in New Mexico. I believe there are no drug courts in the metro court system here, which, you know, we don't really have any drugs problems here in Albuquerque. So that kind of surprises me. I believe there are drug courts in the district.
There's a drug court for second DWI.
For DWI, yes, for second DWI. Yes?
No, we have a juvenile drug court.
In metro court?
No, juvenile in district court.
District court, I was getting to district.
We have an adult felony drug court. We have a metro DUI court. We have a felony DUI court. We have a veterans court, and we have a mental health court, both in metro court and in district court. We are the largest county with the most drug courts in the state.
So, but most of them are in the district court.
Yeah, there's one in metro court.
Okay. So do any of them, well then let me ask you the questions, you have the answers. Do any of them use medication-assisted treatment?
I'll talk, I'm the president of our New Mexico Association of Drug Court Professionals.
Okay.
Okay. Statewide, there are drug courts that use MAP.
Yes.
Medical assistance. Albuquerque does not.
So that's a problem.
But we have representatives from the Veterans District Court right over there.
Yes.
I'm Ginger Varco. I'm the Veterans Court Coordinator for Bernalillo County, and I have numerous participants that for Veterans Court in Bernalillo County. I'm the coordinator. My name's Ginger Varco. We've been up and running since 2011. I have multiple participants that are using medical assisted treatment to overcome their addictions.
Okay, so that's excellent. Actually, there was one survey that Peter Bocart and I were involved in of surveying drug court judges around the state, And I'll always remember the response of one drug court judge that said, "Over my dead body would I use a medication for a drug addict?" And, you know, it goes back to what I said earlier. The last slides I had was stigma, 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 and discrimination. We're not, as the gentleman said from Wisconsin, that's a great video, by the way, similar stories in other states. You know, very conservative governors and legislatures. Texas is another example. Texas, I've been to Texas 6 times training judges. They're not warm and fuzzy in Texas. You know, they're not doing, you know, they're doing what I think is an unbelievable job there of doing something called right on crime. And what how it started was a Republican and Democrat in the legislature said, we're not going to support this appropriation for 2 more prisons. We can't afford this. And so they got a bill together and they actually set aside not behavioral health dollars, not Department of Health dollars, they set aside correctional dollars for behavioral health. And they've been able to close 2 prisons in Texas over the last 5 years. So it does work as it's working in Wisconsin. It doesn't matter what your motivation is. As I always say, I dance with those who brought me. And so it's doing the right thing. We're decreasing the criminal population. So what I would like to propose is an increase in funding and if for district court, an increase in funding, an increased number of judges who are participating. I understand, you can correct me if I'm wrong, that the judges who do drug courts are all voluntary. Yes. So they really kind of do it on the side because they think it's a good thing to do. And, you know, I honor them for that. But with the drug problems that we have in this state, and you saw the efforts that Virginia and the Bernalillo County people are trying to reduce the population of MDC, we really could do a lot more with diversion programs and alternative to incarceration throughout the whole state, but especially here in Bernalillo County. One of the things that, I don't know if you mentioned it, Virginia, but I was just thrilled to hear, talking with Tom Swistak one day when we were out at MDC, that the community custody program actually is now enrolling people in Medicaid and making them eligible at that point, in that community custody for Medicaid services and reimbursement. That's a really big deal, and I'm a congratulations to the Bernalillo County for doing that. What, I got 2 minutes? One? Okay. I really don't have an awful lot more to say except that you heard about the Good Samaritan law. I really think that is a very important thing, that we need to change the Good Samaritan law so people who are on probation or parole can carry naloxone with them and Narcan. And that, you know, shouldn't be a violation of parole. So I think that's a little fix, but it, as was Lisa still here? As Lisa said, it could save many, many more lives. We need to expand, and I already heard about this, but I can't quite imagine the reasons why the Bernalillo, the Albuquerque Police Department doesn't already carry Narcan in their squad cars. I know you've had some discussion with Chief Eden. I used to have discussions when he was the Secretary of Public Safety. And this is a very important thing. The Attorney General of the United States said this is an important thing, and that every federal law enforcement officer should be trained and should be able to use Narcan. And that's huge for the feds to come out and say that. So we're dragging our feet here when that seems kind of odd versus the federal government, having worked for them for a long time. We're dragging our feet here in Albuquerque. So I'm told to wrap it up. This has been an unbelievable day. Wow. So much information. I'm delighted and honored to be a part of it. And thank you for all attending and for listening and staying to the end. Thank you. Yes, questions.
We have about 5 minutes for questions for Dr. Condon and for Virginia.
Idea or a thought that I wanted to share.
Please.
You know, as we, let me not text my daughter while I'm, with the Medicaid coverage of naloxone, one of the things that they're looking into at the Santa Fe County Adult Detention Center is working with the Walgreens that fills the other medications for their detainees upon release, so that when the detainee is leaving the facility, they're leaving with all of the medications that they came in with essentially renewed, and they work with a specific Walgreens. That same Walgreens pharmacists have been trained by Dale and Company, so they have prescriptive authority. The point here is a way of getting Narcan into the hands of your detainees on release once qualified for Medicaid.
They deliver it to the prison, back to the prison?
Yes, it's a smaller, obviously, facility and a smaller scene, but their farm tech drives to, will drive to the Walgreens and pick up the meds, which will include Narcan along with other meds, drives back to the facility, gets that into their property, and then when they leave with Narcan and their allergy, you know, the other medications for chronic illness that they have been filled, and it's all paid for by Medicaid. It's not coming off of the county dime. Yeah.
Sounds like a great program.
Great, thank you. It's something we should consider. Yes,
My name is Michael again, and I own a pharmacy called Barreras Farmacia.
and a restaurant.
And yeah, well, actually, we're having food afterwards, guys, so come on, my happy hour. Just kidding. But I would offer this state the ability to fill their prescriptions for the inmates at my pharmacy at a price probably cheaper than Walgreens and some of the other pharmacies, and we can actually mail it to them, and we can actually save the state money if you people want to do that. So contact me, okay?
Thank you, Mike. Well, I guess we better wrap it up here. We have some closing comments from Dr. Weiss. Is that right? And then that's it. He's a call to action is what we're going to call this, all right?
It's been a long day. I'm going to be brief, try to be brief. It's actually been an amazing day, an inspiring day, and an opportunity to showcase some really heroic people. This is just amazing. We're addressing a huge, huge problem. I think several people have said, you know, this is a crisis. We don't always act that way, but it truly is a crisis. I would like to first thank Commissioner Hart Stebbins for being here. She's the font from which all of this flows, and without her initiation, without her ongoing interest and support and participation, and she certainly does comment from time to time, this wouldn't be happening at all. I'd like to thank all of you who are participants, and we have a wide variety of participants, which is so appropriate given the complexity of this problem and the complexity of its solutions. We have persons here giving voice and providing advocacy on behalf of the persons and families affected by the problem of drug use dependency. We have providers and intermediaries of the personal health care. I'd like to thank Marcia McMurray Avila, who's truly been the heartbeat of this whole effort. She makes the rest of us look good if we look good at all, it's because of her. And she's tireless and a real public health champion. I want to call out to U.S. Attorney Damon Martinez. and just make a particular comment. The approach taken by him should be a model for all of us. I don't know where this comes from, but it seems so obvious. He's identifying a problem. We've got a big drug problem that has huge consequences, and the current system isn't solving that problem. It's addressing the problem, it's not solving the problem. And so he's starting with a fresh slate. He says, you know, we've been doing things, it's not working at least adequately. So he comes into our community of concerned advocates and treatment people and educators and so forth and so on and says, hey, we've got a problem, current things aren't working, let's get together and figure it out. For him, the first person plural is all of us. He's asking for coalitions, he's asking for cooperation, partnerships, ideas, energy, action, and results. Pretty obvious, but I tell you, it's very refreshing. I want to call out to Chancellor Roth, who was unable to stay here for the full meeting. UNM has been doing a lot. This whole initiative is benefited by a fair number of people on our implementation teams, as well as Harris and myself, who are affiliated with UNM. UNM has programs that Dr. Roth outlined. They're doing some pretty special things. And the fact that he is willing to stand up here at this podium and make a commitment to work with all of us and commit himself to getting this job done is just very, very encouraging. And I think it's not that UNM hasn't been doing anything, but to date, they haven't been as engaged with our particular initiative as we might have hoped. And I think we can truly gain if that relationship can prosper. The subtitle of this event is, "Why Aren't We There Yet?" And I think we can say a couple of things. First, let's acknowledge, for heaven's sakes, there really is progress. We may not be all the way there yet, but we can see signs, as evidenced again and again today. First of all, some of those curves are beginning to turn and turning in the right direction. To the extent that they're starting to turn, we're going to take full credit, even though some of them started to turn a little bit before we began. And the ones that haven't started to turn, that's somebody else isn't doing the job. Just kidding. But we really are making some progress, and it's very exciting to see. And even though, you know, we're still by no means where we want to be, even though those curves are turning, we have got a long way to go. But it is so encouraging to see action beginning to pay off. That is so excellent. We've got some decrease in the deaths. Harris, I think, did a great analysis. Seems to be the prescription drugs. Excuse me. There are some initiatives which undoubtedly are contributing to that. The PMP, Prescription Monitoring Program, is an enormously important tool, and it's only going to get better. That's going to make, I think it's already making a difference, and it's going to continue to make a difference. So that is great. The prescribing guidelines, Governor's Pain Management Group, Advisory Council, that's, I think, going to make a big difference. I think it's already having make a difference. This is just straight water, right? Thank you. Nevertheless, we do still have a big problem, and we just absolutely are not going to let up. We still have a blight. Our ranking, our statistics, other states know about us, and we've got to fix this. It affects so much. I mean, it's the problem in itself, and the people that are hurting from drugs. This is hurting us as a state. We puff out our chests and talk about our ambitions for economic development. We could make some steps in economic development, but come on, we got to clean this problem up. It's holding us back, and it's going to continue to do that until we really do it. We're all stakeholders in that. I just want to make a few summary remarks. The outcome of this summit should be setting our goals and setting them at a high level. We shouldn't be modest in our goals. If we're modest, hey, we're still going to be running at the back of the pack. We've got to set high goals and get serious about them. And we need to hold ourselves accountable until those goals are reached. I'd like to draw a bit upon Marcia's earlier comments on collective impact. We need, as stakeholders, we need to commit ourselves to shared objectives. We need to understand that it's not just me responsible for my program. We are all responsible for the final outcome. And that responsibility does not stop until those outcomes are reached. And that's what accountability is all about. We can't hide, or we shouldn't allow ourselves to hide. And we all need to stay in the game until the job is done. It's not, well, I've done my part, now you go ahead and get your act together. That's not going to work. I'd like to point out that a lot of our discussions today, treatment, Narcan, we're talking about individual health or social services, and that's important. We need to get that fixed, and there are major problems in terms of our shortfall in treatment. But importantly, and implied, but not necessarily made explicit, this is a public health problem. What's the difference? Public health is looking at the impact on the population. It's not looking just at impact on what we can do for an individual who is afflicted with this problem. That's important too, obviously. But it's not enough to treat individuals well and effectively. We've got to make sure we reach our goals on a population scale. So we can have great programs, but if that curve isn't turning, we've got to go back to the drawing board. So that's an important distinction. We can have great programs providing individual services, but when we step back and look, they aren't scaled to being applied on a population basis. That's a challenge. We've got to think in those terms. Likewise, public health looks at it not only from the problem of how do we scale it up, usually meaning how do we get the money to scale it up, but what new policies, what new solutions, what new environmental interventions can we think of to move this forward on a population basis? So both of those tracks are critically important. What are the barriers? I'll just tick through some of these. They've been mentioned. I think there's a failure at all levels to accept that those with addiction have a chronic relapsing disease that Dr. Condon so eloquently demonstrated and informed us about. we can talk about, yeah, I believe it, but then at another part of my brain, I'm saying, yeah, but those are still addicted people, and it's their fault, or whatever. We've got to get past that, and we've got to be aggressive in saying that and saying that again until that turns. And there are other diseases that have had stigma that have turned that corner. And we've got to do the same thing with the people who have drug use disorders. That's going to take work. It's a major, major barrier, and I think it underlies so much of the viscosity in getting this problem solved. I think at times we fail to truly remember how this blight undermines so much else that we desire and desperately need. That was the basis of my remarks earlier today about the impact of this on schools. And that schools are just one thing to put out on the table. That impact is taking place everywhere. It affects us all, and we can't forget that. And so stigma, the insidiousness of stigma is that it allows us to deprioritize. It allows us to defer action. We say, yeah, there's a big problem here, but we got another one that's more important. So let's set that one aside, or we'll humor those people along. It's an excuse. It becomes the excuse. And you see that again and again and again in the lowballing of the funding of the programs that we need to get the job done, the bills that don't quite get to be heard in committee. It's an excuse for vetoes. I don't know. The specter of stigma is there all over the place, and that's just got to be addressed. We have another barrier is our own organizational structures. There's so much, just listening to Melissa, others today say, well, the answer is so simple, and yet it doesn't happen. Organizational rigidity. It just doesn't, the solutions we need don't channel through the channels that organizations normally use. And so it's always a push, but the ossification of organizational structure holds us back. And I think those of us who are involved with organizations need to look seriously at that. That's got to be done. There's another organizational structural issue, and I've invented a word. Take out your pencils. It's called, I got to go slowly to pronounce it right. It's called centripetality. Centripetality. What is that? Centripetal. Remember your physics? Centripetal is as opposed to centrifugal, which allows the water to stay in the bucket as you stir around your head, Centripetal is the force that comes back to the center. So centripetality is that force within organizational structures that cause them to consider, what's in it for me? How is it going to affect me? Am I going to have to make any compromises? We got to have an executive session so we can talk about what the impact of this innovation is going to be on our organization. That is so much part of our culture. And it keeps organizations from trusting each other, keeps organizations from sharing objectives, it keeps organizations from celebrating another organization's success. And we've got to look at that and understand that that's out there, and it keeps us from developing the kinds of partnerships to get the alignments that Marcia was talking about this morning. So write that down, centripetality. I'll have the spelling in the final report. And the final organizational structure is, that's what we see again and again, is organizational hubris. Well, we've got great program and we're doing our part. How can you find fault because we're doing God's work? Well, if the job isn't getting done, we're not doing enough. And it's just not sufficient. And organizations walk away from the problem thinking, well, I've got my part of it done. That's hubris. And we've got to, as many of us who are involved in organizations, have got to recognize this and understand that behind the solution is going to be partners. It's got to be people working together on commonality. This is a tough call, Marcia, in our culture. And we got to just keep seeing that. Otherwise, we're condemning ourselves to the status quo. And that's not going to get us there. We can talk and talk and talk. But until we start working together, we're not going to get that done. So I'm going to say a couple of more words about what the requirements are. I've got 4 items: leadership, accountability, listening to the advocates, and state participation. We're talking about now trying to get solutions in our county. Leaderships. Leaders need to be committed. They need to be problem solvers. They need to follow through. They need to be willing to embrace partnerships, even with some of the people with whom they compete in other contexts. And they don't drop their commitment just because their attorneys say it's not possible. Or middle managers say it can't be done by us. No, leaders solve those problems. That's what leadership is all about. And we should demand that from our leaders. So that's my requirements. Not on my list, not on that list for requirements is money. Oops. Everybody says, well, we'd do it if we had the money. I mean, we're doing as much as we can, but we need money to do more. And that's probably true. Of course we need money. I would like to say there's an awful lot of money already being spent. There is a lot of money being spent. I'm not saying we don't need more money, but think about it. Medicaid, expansion of Medicaid dumps huge amounts of money right into some of the core populations that are being affected. And it was pointed out earlier, we're still not using that Medicaid money to its best effect. I think Lisa said that. We've got a ways to go with Medicaid. I got to say, personally, I get a really awful feeling in my stomach when I hear people say, well, we can't afford the state's portion of Medicaid. We can't afford 10%. We can't accept 90% from somebody else. There's got to be something wrong with the people who argue that. And I say, they're not thinking hard enough. How can we turn down, in some instances, 100% because we can't afford it? I don't think those people are thinking hard enough. There's got to be an answer. And that's Medicaid. Analysts point out again and again about the money that is misspent on services that aren't working. There's a lot of wasted money. And some of it's because the services are just bad ideas, but a lot of them are services that would work if only we applied them a little longer. That was talked about this morning, the difference between how we treat addiction compared to diabetes. If you got diabetes, I mean, you got people standing around and gathering around to try to take care of you for the rest of your life. If you got addiction, you may get detoxed, and then sooner or later, generally sooner, you're on your own with your chronic relapsing disease. So we got to spend our money better and more effectively. Otherwise, we're just going to be spending it over and over again, spinning our wheels on conditions that don't get the job done. The other big source is that we have good ideas that work, that actually end up saving money if we hadn't spent them that way. And Mike Robertson gave an example about the Heading Home Project, which saves public sources about 30% of what they would have spent had not that project, supportive housing, been on a high-risk group, been implemented. So, okay, you're spending money that's actually saving you money that you, without that program, you would have lost. Yet, where does that savings go? Everybody's got their hands reaching out and pull it away towards their own programs. Nobody bothers to save a little bit of that to support the money, to support the program that generated that savings. And that program goes away, and we're back to where we were in the. So I'm not an organizational management kind of person, but there are real experts out there. We need to get those people to help us figure out how to identify the savings, sequester the savings in order to pay back the investors, the investment in that savings, and keep the program going and still have a little left over to dump back into the system. That seems like that should work, and yet we don't have a mechanism of identifying and sequestering the savings to do that. That's an organizational problem. There's got to be somebody smart enough out there to figure that out and how we can make that work in government. That should be a source of funds. Well, the final thing I'd like to say about, about not enough money is, okay, there isn't really enough money. So what's Plan B? Plan A is, I need money, and if I don't get it, I need money. Plan B is, I need money, I don't get it, so now I'm going to figure out what to do with less money and get on with it. We perhaps need some new models. We need to do it more efficiently. We need to maybe break some rules to get the job done. But that's what creativity is, and we've got smart people that are coming up with solutions. Project ECHO has got great solutions of doing things in a new way. We have the professor of neurosurgery at UNM, who single-handedly is trying to create a system of neurosurgery services statewide where there aren't neurosurgeons. I don't know whether that's going to work or not, but if he thinks it does, I'll go with it. And you know, he's got an idea. Let's move with it. So we got to go with Plan B if Plan A doesn't come up. So yeah, we need money, but my antenna go up. Somebody's whining and is using this as an excuse for not really changing anything. And we got to move on and come up with solutions. Well, another quote, we can't raise taxes. No, you can't raise taxes. Can't raise taxes. As already noted, voters in Bernalillo County in November, 69% said that they'd be happy to have an increase in the gross receipts tax to deal with behavioral health. Well, what do you mean, can't raise taxes? Maybe we can. Harris points out our alcohol tax in this state is a fixed amount imposed decades ago. Price of booze has gone up. That tax as a percent has been falling ever since. So that's a tax that was voted in, and it has lost its value in terms of amount, and maybe it's time to restore the original tax that the voters voted in. Where are our politicians? Why are we quivering so about raising taxes when the tax has been falling? It's just to throw it out there. Why can't we just keep asking that? And finally, maybe the taxpayers are simply waiting to have the confidence that their taxes are being well spent on effective programs. Well, that's our job, is to present some effective programs. I've got faith that our taxpayers aren't as afraid of taxes as our politicians seem to be. So I just say that I don't know, but that's just kind of my sense. I'm not going to go through all of our areas today. We've had scores of recommendations, scores of examples of things that work, scores of examples of problems we're dealing with and how to overcome them. We'll be putting out a report. The proceedings, the slides, the videos, these will get up on the web at the Bernalillo County Community, what are you? Community Health Council. And the attendees, addresses, all of that stuff will be online. And we'll continue with our, excuse me, if I survive, we'll continue with our implementation teams. Please look at the commitment form, see where you might be able to start participating. I've had several people approach me saying they really want to do this. Please fill out your evaluation. We'll probably have another summit, next peak on this chain of mountains in a year or so. But we've come a long way in the last year and a half. I think, how many people have said that today, just looking around and listening? This is we're living in a different era in terms of addressing this. So thank you, Commissioner, and the implementation teams who've been working hard. We really have gone a long way. I am actually very optimistic that we can get this job done. So stop there.